Today we're covering sodium imbalances, a critical topic for your nursing exam. The NCLEX loves to test this because sodium's primary role affects fluid balance and neurological function, making it a high-stakes concept for patient safety. Let's start with hyponatremia, where the serum sodium is less than 135. The exam will trick you into thinking it's always a sodium loss problem, but it's more often a water gain problem. Think of conditions that cause the body to hold on to excess water, diluting the sodium. The classic example is SIADH, the syndrome of inappropriate antidiuretic hormone, where the body produces too much ADH and retains water. Other causes include heart failure, excessive water intake, and using thiazide diuretics. Clinically, hyponatremia is all about the brain. The low sodium concentration in the blood causes fluid to shift into the brain cells, leading to cerebral edema. This is why the hallmark symptoms are neurological. Your patient will present with headache, confusion, and lethargy. As it worsens, you'll see seizures and eventually coma. For the exam, if you see a patient with a known cause of SIADH, like small cell lung cancer, who is now confused, your priority nursing action is to implement seizure precautions. Now let's discuss hypernatremia, a serum sodium greater than 145. This is typically a water loss problem, not a sodium gain problem. The body loses more water than sodium, concentrating the sodium that remains. The prime example is diabetes insipidus, where there is a deficiency of ADH, leading to massive water loss through urination. Other causes are dehydration from fever or sweating, and high-sodium enteral tube feedings without adequate water flushes. The symptoms of hypernatremia also have a strong neurological component because the high sodium in the blood pulls water out of brain cells, causing them to shrink. This leads to restlessness, agitation, twitching, and lethargy. The exam might present a scenario with an unconscious patient receiving tube feeds who develops twitching and a high sodium level. The priority intervention is to notify the provider and advocate for free water flushes. The most critical point for both conditions and a favorite exam topic is the danger of rapid correction. Here is the mnemonic to remember. Low to high, the pons will die. High to low, the brain will blow. When you correct hyponatremia too quickly, going from low to high sodium, you risk causing central pontine myelinolysis, a severe neurological disorder. This is why hypertonic saline is administered slowly and cautiously in an ICU setting. Conversely, when you correct hypernatremia too quickly by giving hypotonic fluids rapidly, going from high to low sodium, you risk causing a sudden shift of fluid back into the brain cells, leading to severe cerebral edema. Therefore, on the exam, always choose the answer that reflects slow, careful correction and frequent neurological monitoring. Never pick the option that suggests a rapid infusion to fix the number quickly. Your priority is always patient safety and neurological stability, not just normalizing a lab value.